Hello, everyone. My name is Dr. Julie Richard. I am one of the psychiatrists with the Prevention and Early Intervention Program for Psychosis, or as we call it, PEPP, at London Health Sciences Centre. I would like to welcome you to our 2020 Family Workshop. We've been doing this Family Workshop for 20 years, and sadly, this is the very first time that we've had to do this virtually because of the COVID-19 pandemic. But although we couldn't gather together, we felt it was very important to still give you the chance to have this information and to be able to communicate with us and discuss with us some of the concerns and questions you have about your loved one's journey through psychosis and through our program. At the end of the talk, you'll have an opportunity to leave questions in our comment section, or you can email them directly to the email indicated on your invite newsletter. And then on our Family Workshop Day, we'll be doing a question and answer through WebEx to allow for some discussion about the questions that you have. So by now you've probably heard the word psychosis used to describe what your family member is going through. And that can be a confusing word to understand. Psychosis refers to a loss of contact with reality in which people have trouble distinguishing between what is real and not real. And this is called a psychotic episode. For some of our clients, it comes on quite suddenly, and for others, very gradually. For some, there are some early warning signs: social withdrawal, feeling suspicious, anxious, irritable, or depressed. But many of these early warning signs are very nonspecific. When someone's going through a psychotic episode, they can have changes in their thinking, in their perception, their beliefs, their mood, and their behavior. And we'll be going through these each in this talk. Changes in thinking is really relevant. An individual who's going through a psychotic episode can have difficulty when they're trying to concentrate or even just follow a conversation or remember something. We know that psychosis affects all the brain, including the parts that are relevant for memory and processing. Our patients will tell us that thoughts can feel jumbled or not connected, and you can see this sometimes in a decline at work or school, inattention, forgetfulness, or difficulty maintaining conversations and relationships. What's often seen at some point after that is what's called delusions, which are changes in an individual's beliefs. Delusions are fixed false beliefs which cannot be corrected by reasoning. Examples can include paranoid delusions, delusions of reference, body delusions, what we call erotomania, which is a romantic delusion or a delusion of infidelity, or what we call delusions of grandeur. And I'll go through some specific examples of these. Paranoid or persecutory delusions are quite common. I have one gentleman who felt that he was the reincarnation of a rapper called Tupac, who apparently was murdered. So my patient informed me, and then he felt that he was being persecuted and murdered because he too was Tupac. Delusions of reference are very common. This happens when you notice something that's usual in your environment, like somebody standing there, somebody walking by, or a particular sign, but you feel that there's a very particular meaning that only you can see, whereas other people wouldn't see that meaning. The example I give here is somebody who notices a man at a bus stop who's wearing a yellow hat, and who immediately thinks, oh, that yellow hat must mean that he's a CSIS agent. These ideas are not connected, but to someone in psychosis, things that are seemingly unconnected, like a yellow hat and CSIS, can become connected. Delusions of infidelity and erotomania aren't as common. So in a delusion of infidelity, someone might feel, if someone's not answering their phone by the fourth ring, it means they're being unfaithful. On the flip side, what we call erotomanic delusions are beliefs that somebody is romantically attached to you, even though there's evidence to the contrary. For instance, I had one client who was convinced that Eminem wanted to be with her, and she would decipher the lyrics in a way that made it feel that way to her. A grandiose delusion is anything that is a power or ability or a special talent or a status in life that is not consistent with reality. For instance, feeling that you have billions in a Cayman bank account for discovering some mathematical formulas. Other types can include health or body delusions. I have clients who describe feeling they have microphones in their hair follicles, that they might be missing a part of their body. And even when you try to show them, for instance, on an X-ray or CAT scan, that that's not accurate, it doesn't matter. They continue to feel that it's how they feel it in their body. Some people will also have religious delusions, although we don't see these as much anymore. I had a client who felt that it was her job to release Satan from hell, and she was debating with the angels about this, and they didn't want her to let Satan out because he had a quote-unquote bad track record. Or another client who felt that God was trying to test him for bravery and asked him to do things that were frightening to him. The important thing to know about delusions is that these feel completely real to someone going through them. It's not a matter of opinion or debate. For somebody going through psychosis, these beliefs feel completely real. I put this up because a client of mine in particular had a very fixed delusion that when he went out into a public place, a mall, a restaurant, out on the street, that there was meaning to whether or not people around him had caps on forwards or backwards. And so you can see here in this picture of just a random street, one person has a cap on forward, the other one has it on backward. My patient felt that if somebody had caps on forward, then they were part of a group that was protecting him. If they had caps on backwards, they were part of a group that would try to harm him. And so in any environment he was in, he would always weigh the people with caps forward versus backward to decide if he could stay there or not. And he talked about it so much that it's something that I must have subconsciously taken in, because I'll even notice when I'm out that I'll kind of notice it and think of him when I notice people wearing their ball caps. But this is something that for us would be commonplace kind of background noise that for someone in psychosis becomes highly relevant. And again, I can't stress how biological this is, that people don't have a choice about this. This is the brain's chemistry making connections even when there's none. So beyond changes in beliefs, people can have complete changes in perception. So they can actually hear, see, taste, or feel something that's not actually there. These changes are called hallucinations. Most common by far is auditory. Voices can be conversing, commenting, commanding, and people find it to be quite frightening and again sound exactly as a real conversation or voice would. Some people describe changes in mood. People often describe excitation, depression, feeling anxious, and this can be leading up to the psychotic episode and during the psychotic episode. Other people find that they have less emotion, so that emotions become blunted. People may become flat, uninterested in the world around them. Another important set of symptoms to talk about are what we call negative symptoms. This is a common part of the illness, but is not often what gets people into treatment. What usually gets people to come into treatment are the hallucinations, delusions, odd behavior, agitation, or anger towards family and friends. But negative symptoms are an equal part of the illness. Typically what we see are things like apathy, social withdrawal, functional decline, worse self-care, and what you may notice is that if an individual is experiencing this, they may not be aware or bothered by these changes, but the people around them notice these changes. This can all culminate in significant changes in behavior. During a psychotic episode, people can act very differently from how they normally do. This can be due to having hallucinations, being afraid of delusions. If you can imagine being in a very nightmarish reality where the reality might be that you're being targeted or monitored or bugged, this is very frightening, and it feels again completely real. So it's a traumatic experience, no different than if it happened to any of us actually, right? These are very traumatic things that somebody might go through in a psychosis, and understandably can lead to significant changes in behavior. Having said that, to describe what this would be like to have voices, to feel that your world is changing, that you can't trust people in your world, that people are following you, changes at school, withdrawing from relationships. It's surprising to think, but many young people who develop psychosis don't actually see that they have a problem. And this is really common, but understandably frightening, frustrating to families who clearly see a change in a young person's behavior. And this is related to what we call insight. So what insight means is the ability or capacity to appreciate the nature of a situation. This can come to include being aware that you have symptoms, understanding that the symptoms are due to a disorder, understanding specific symptoms and signs of the disorder, and understanding the consequences of the disorder. For instance, recognizing that these changes in your mental health are leading to not being able to go to school, not being able to go to work, arguments with friends or family, and then understanding the need for treatment. These are all components of what we call insight. Insight can rarely remain intact during an episode. That's pretty rare, but sometimes that can happen. More commonly, what we see is that people do not have insight during their episode, but insight does improve after the symptoms go away. For some people, though, insight will continue to be a problem even when the symptoms are gone. And some people have what we call partial insight. So they might say, well, yes, the treatment helps, or I'll take the treatment, but it's only going to help me for sleep. So we see a wide range of insight. And this is different than what we see for most other illnesses, even in psychiatry, that we see somebody with depression or anxiety will typically recognize those symptoms as such. But in psychosis, it's really neurological. People don't recognize these symptoms as part of a mental illness. So those are some thoughts about symptoms, and those are some of the symptoms you might have seen in your loved one as part of a psychotic episode. Once we start working with young people, I would say the most common question we get is, what is the diagnosis? So a psychosis is an episode, but what is the actual diagnosis that my loved one has? There are many diagnoses that have a psychotic episode as part of them, and I've listed them here. So at the top is schizophrenia. There's other variations of that. That are different depending on time criteria and presence of other symptoms, called schizophreniform or schizoaffective disorder, delusional disorder. Going down the list, some people have rarely a psychotic disorder due to a general medical condition. For young people, it's extremely, extremely rare, except if you're going to the hospital that Dr. House is in, then it happens every week. Substance-induced psychotic disorder we'll talk about, because that's actually a much more common thing that we see. And not otherwise specified just means that we don't know yet. And I also put a star at the bottom beside bipolar disorder, because people can certainly have psychotic episodes as part of bipolar disorder. And in our clinic, probably about 10 to 15% of people we work with ultimately end up having that diagnosis, even though it's a mood disorder and not a primary psychotic disorder. So keep in mind, when it comes to the diagnoses on that list, most of them have a requirement of a certain minimum duration of illness to meet the criteria, and then all of them have a constellation of different or a certain number of specific symptoms in order to meet the criteria. So in order to determine which one is most applicable for your loved one, it may take some time and extra assessment to make sure that the right diagnosis is reached. The presence of substance use or other mental health symptoms can make it really difficult to establish a clear diagnosis early on. And this is common, especially when we see that many young people are now using cannabis regularly or might have other mental health diagnoses already, like depression, obsessive compulsive disorder. It can take some time for us to clearly diagnose the psychotic disorder. Regardless of the ultimate diagnosis, though, treating the psychotic disorder is key to make sure that somebody is treated out of their psychotic episode as soon as possible. So some facts about psychosis. First of all, it's not all that rare. So the lifetime risk of all psychotic disorders, if you add up all of those ones on the list, is about 3 per 100. When you think of an average high school of about 1,000 kids, that's not an insignificant number. And in London, we see that. We're very busy. We get several referrals a month. So these are illnesses that are common. The lifetime risk of schizophrenia itself is 1 in 100, and the incidence of new cases per year is about 15 to 20 per 100,000, and I would say we see that in our clinic as well, with a city the size of London. So we are busy. These things are common. It occurs worldwide, regardless of race, social class, intelligence, culture, gender, or background. And this is really important, right? So there is something that is innate about being human that puts us at risk of having a psychotic disorder that has nothing to do with where we've come from or culture or part of the world, that there is something about being human that predisposes us to having mental health and specifically psychotic disorders. What we do know, though, is that it develops almost always when people are young, between the ages of 16 and 25, a little bit later for women. but there is something about a brain that has just finished developing that seems to be especially vulnerable to developing a psychotic disorder. The exact cause is not known. And this is very important. If I could ask you as families to do one thing today, it would be to not look and trying to find a reason or a trigger or a specific cause. Unfortunately, psychotic disorders are medical bad luck. So the first thing I always like to say, and it's more effective, I think, when we're in the room together, is that this is not your fault. It's not your loved one's fault. We are all born with different risks for all kinds of disorders, thyroid problems, diabetes, seizure disorders, and it's medical bad luck that this happened to your loved one. So I think as parents, we often search for whys, or was there something I could have done different? And I want to reassure you as best I can that this is nobody's fault. It's bad luck. And it happens all over the world. We do know that there's a slight risk increase with genetics. So the risk increases 10 times if a first-degree relative has the illness, 40 times if both parents have the illness, or if an identical twin has the illness. But if you turn that around, it's not all genetic. Otherwise, 100% of identical twins would get the illness, and that's not the case. So we know that genes only play a small part. And even when we look at first-degree relatives, so parents, if a parent has the illness, a young person's risk goes from 1% to 10%, which seems high, but then it's still a 90% chance that they wouldn't get it. So genetics counts for some, but not all of our understanding of the illness. Cannabis and other drugs, we're going to come back to and talk a little bit more about that because that deserves a bit more explanation. The other ones that are associated, but we don't really understand the association. There's a very small increase of risk with birth complications, any birth complications, forceps, traumatic birth, not enough oxygen at the beginning, but there's no specific birth complication that it's associated with. And certainly high degrees of stress or trauma. So this would have to be to a level of trauma or having to migrate, something that is extremely disruptive in a young person's life. We will talk a little more about specifically cannabis. The landscape has changed a lot since legalization, so it is really important to talk about. We do know that it's the most commonly used drug among Canadian youth, and that a third of all Ontario students grades 7 to 12 have used in the last year. So it's quite common, and since legalization, it's also kind of lost any of that concern around it, right? It's very open. People now grow their own dispensaries. Make products look fun and young. So, that decriminalization has really kind of changed the image of cannabis as well. The problem, though, is that it's still a medical risk. Even though it's no longer criminal, it's still a medical risk, especially for young people. Recent studies strongly suggest that cannabis use can increase both the incidence and persistence of psychotic symptoms in vulnerable individuals, especially early persistent users. So what that means is that for a young person who starts using in their teens and uses regularly, they over time develop a higher risk of developing a psychotic disorder than someone who didn't. But this is really for people who have used regularly in their adolescent years. If you want to learn more about it, there's a great website there, cannabisanpsychosis.ca. I highly recommend you check it out. It's a fantastic website that talks more about the relationship between cannabis and psychosis. Just before I move on to early intervention, the last thing I'll say about cannabis is once somebody has had an episode of psychosis, cannabis use can make it more difficult to regain wellness, to return to remission. And so we do counsel young people to avoid cannabis use. If your loved one does use cannabis and isn't stopping right away, we do know that this is a process, that it may take some time for them to see that it is not good for their mental health. So it may take some time for them to stop using and to really make that connection. So be patient, but continue communicating about it. So early intervention. The goals of our program are to reduce the length of untreated psychosis because we know the longer someone's in psychosis, the worse their outcomes, and to provide optimum management of psychosis in the early years after onset. This is the only researchy slide I'll put up, but it's really important. So this was the very first episode study that was done. This was an American researcher who kind of looked at the state of mental health treatment and saw that really all that was being done in a regular way was providing medications to individuals with schizophrenia and other psychotic disorders. And so what this researcher, Hoggarty, did was he did a large study involving many people in the early years with schizophrenia and other psychotic disorders and divided them randomly into 4 groups. All 4 groups got medication. The first group got medication only. So this would be, so they would still get a doctor visit. They would come, once every couple of weeks to see a doctor, get the medications, see them for a 20-minute visit, and send them back out the door. The second group got social skills training and medication. Social skills training can involve things like skills group, cooking group, social outings, and this would happen in tandem with the doctor visits. The third group got a family intervention, so a family workshop like what we're doing, or ideally what we would like to do if we could meet in person, and medication. So that group got lots of contact with parents, family members, as well as medication for the client. And the last group got everything. So they got medication, social skills, support groups, family intervention, and then the researcher measured the relapse rates at 1 and 2 years. And if you look at that, it really speaks to the fact that just providing medication alone is not enough. That in order to ensure that somebody doesn't relapse back into their illness, it requires a real wraparound approach of social skills, skill building, family intervention, and family support. And you can have really dramatic results to outcomes. And I'm really pleased that in our program, our outcomes are very good because we have this approach. So how do individuals stay well after a first episode of psychosis? The first stage of treatment focuses on remission. So remission means getting rid of the symptoms, so getting rid of the hallucinations, the delusions, and generally speaking, medication and close follow-up allows individuals to remain in remission from their symptoms. But remission is not enough. For individuals to achieve and sustain wellness, efforts really need to be focused on recovery after remission has been achieved. And recovery is a much more important outcome for our clients, right? Being out of hospital, being out of a psychosis, those are really important steps, but only the first steps to a young person feeling recovered from their illness. What is recovery? So unlike remission, which just refers to the absence of symptoms of psychosis, recovery is a client-centered concept that incorporates quality of life, functionality, subjective well-being. So everyone's definition of recovery is going to be a little bit different because everyone is different. In our program, we did some research looking at indicators of recovery. So we asked large groups of our clients, what do you think recovery looks like? And many of them, so 68%, said that meaningful activities, going back to some kind of meaningful activity, was an indicator of recovery. Feeling good, feeling content, and having less or no psychotic symptoms were also important. And then having healthy relationships was up there as well as being a really important indicator of recovery. We asked clients what were the most important factors that help facilitate your recovery, and our clients said first and foremost social support from peers, friends, family support, medication, personal agency, which just means feeling that you have control over your life, and role resumption. So getting back to the roles you had before. If you worked, if you were a student, if you had a boyfriend, girlfriend, getting back to these things helped people to feel that they were recovering. And I really do want to stress that there is hope, right? That the outcomes for individuals treated in a first episode psychosis program are very good. So with wraparound support, and you'll hear a bit more about case management from Jill Lynch and Josie Swan Marison when they give their portion of our workshop, with the right level of support from our team, people can do well, right? They get back to school, they get back to work. We have great working relationships with our schools in London as well as with employers to help support people go back in a gradual way. And we see that people do well. These are some quotes from our own clients when we asked them what recovery means. So one client said recovery is self-awareness and having more control over your life, valuing yourself, taking advantage of opportunities, having a passion for life, getting rid of the past and moving forward, having faith in yourself. Another client said that recovery is coming to terms with what happened, reinterpreting the past, getting used to medication, being among people, talking to them and getting on with it, willingness to come to the clinic, and being willing to come to treatment. What gets in the way of recovery? Lots of things. Feeling frustrated, recovery feels very slow to many people. Depression, social isolation, especially right now during the COVID pandemic, social isolation is a huge problem. We're not able to provide the same level of in-person support we usually do, and we know it's affecting our clients. Feeling socially anxious around people, lower self-esteem, difficulty accepting that they have an illness, trouble accepting support and working with the treatment team, and stigma, right? There's a lot of stigma around mental illness, particularly psychotic disorders, and it's really difficult for our clients to come to terms with this. Last couple of points, because for some people listening to this lecture, there will have been challenges with an individual who you know needs help, but they're not wanting to access help and feeling very stuck. So I just wanted to go over a couple of slides about our Mental Health Act to know how Ontario legislation can help support people to get into treatment if they don't want to. The first thing to know about is the Form 1. So any doctor in Ontario, surgeon, family doctor, psychiatrist, can issue a Form 1 under the Mental Health Act if there is a presence of a mental illness and evidence of serious risk of harm to self or others, or serious risk of physical impairment to the individual. And the doctor must have seen the patient within the last 7 days to issue this. So maybe a young person won't see a psychiatrist, but maybe they'll go to a walk-in clinic. Even that walk-in clinic doctor can issue a Form 1 for a psychiatric assessment. Failing that, if somebody won't go to any kind of doctor, families can go to the Justice of the Peace to get what's called a Form 2. It's the exact same criteria, but family would go before the Justice of the Peace to explain the situation of the person, why they think there's a mental illness, and then the Justice of the Peace decides if the criteria are met to issue a Form 2, in which case police would bring the individual to the hospital for a psychiatric assessment. And I won't go through it, but I've left the more detailed information here about what the requirement is for a Form 2. The last piece of legislation that's worth knowing about is what's called a community treatment order. So this is a formal agreement between the physician and the patient, or more commonly the physician and the treatment decision maker, which is often parents, that the client will attend appointments and take treatment as prescribed. Worst case scenario, if somebody doesn't comply with it, is that it could result in a mandatory assessment, even if the symptoms haven't come back yet. The purpose of community treatment orders is to prevent relapse and rehospitalization. In order to have one of those as part of care, there has to be a history of previous psychiatric treatment or previous hospitalization. So it's not done within the first episode because there has to be some prior evidence of treatment and improvement with treatment. And a community treatment order lasts for 6 months, and a client could appeal it if they wanted to. And so those are just some important points to know about some of the tools that we have within the Mental Health Act to make sure that people can be assessed and get access to treatment, especially when they don't have insight into their illness. I'm going to leave some resources here that I think would be helpful. The first is a great website with lots of tools, earlypsychosis.ca, lots of really good downloads tools, including some downloads in different languages as well. The second one is a great book, I Am Not Sick, I Don't Need Help. This is specifically for families with a loved one who doesn't have insight into their illness. This psychologist has some great advice on how to communicate with your loved one when they don't see they have an illness. And the last three are very good comprehensive guides for families caring for someone who has a primary psychotic illness like schizophrenia. So I just really want to say thank you to everyone who tuned into this. I recognize that it's not nearly the same as being able to meet in person and share as a group and be able to ask questions and discuss things in real time. But it's really important to us that as families who are coming into our program and who are dealing with this now during this pandemic, that you don't lose the chance to have this information and that we have some way to be able to discuss and communicate. This is our trial run, and so we thank you for your patience with it, and I look forward to answering your questions and having a discussion in the live portion in our family workshop. So thank you very much.